And when it comes to quality of life, how do you assess and address quality of life in patients receiving Enliven? And have you observed improvements compared to prior therapies? What were some of those kind of benchmarks?
Yeah, in a phase one study, of course, we have strict rules according to the study design and the registration, large questionnaires, and so on. But I want to more focus on the daily routine. In the daily routine, I think we should consider quality of life in the discussion with the patients. Some colleagues use questionnaires, which can be, of course, simplified compared to the questionnaires in clinical trials. Some patients like this to fill in a questionnaire before they talk to the doctor, but in the discussion with the patient, it's so important to focus on quality of life as well, to consider the daily problems of the patients and not only the lab values and the clinical symptoms.
Mhm. Um, so let's just talk a little bit about, mutation coverage and mechanistic insights, just kind of going back to that. So in your presentation, was there evidence of any differential activity against specific mutations like T3 15I or those emerging after a um, failure?
We know that a patient with a mutation has a different sensitivity profile to the drugs than a patient with unmutated BCR-ABL. And that's very specific according to the specific mutation and very specific according to the drug which is being used. Therefore, we need tables. We need a guidance which drug could be used at which dose in which mutations. That's obvious in the phase one trial with ENLIVEN 01. Here we know from preclinical analysis which mutations are sensitive and require the standard dose. Of course, in the phase one, we have all the doses available because we did a stepwise approach, but not systematically according to the mutation. Therefore, what I already mentioned, this cohort with the 315 mutation, which is, I think, the most important and most frequent mutation, was implemented to have a clear guidance eventually which dose should be used with this mutation. Maybe a little bit higher than the standard dose which comes out, but that's still open in the phase one. For asciminib, we know these results. We know that asciminib inhibits this 315 mutation, but requires a higher dose. We need a five-fold higher dose than in the standard situation. Standard situation is 80 milligrams per day. For 315, we need 400 milligrams per day. But it's manageable and therefore important that we design an early clinical trial like a phase one trial in a way to be very versatile eventually when it comes to resistant mutations and to know which dose should be used in which situation.